So moving forward, now you have the basic orientation of the lumbosacral plexus. Now, how are you going to approach a patient with foot drop, right? So first you will find out what all is there in the motor weakness in your patient, okay? Now your patient has a foot drop, right? So definitely the ankle dorsiflexion is weak, which means the tibialis anterior supplied by the deep peroneal nerve is weak, right? So at least that much information we have. But how do we go further is by testing the other muscles, okay? So the next that you are going to check is the ankle eversion, okay? So once you get a patient with an ankle dorsiflexion weakness, check for the ankle eversion weak. Because if your patient, along with the foot drop, also has difficulty in everting the ankle, it means that the peroneus longus is also weak, which means that the lesion is not only in the deep peroneal nerve, it is beyond the deep peroneal nerve. That means the lesion is at the level of common peroneal nerve. Okay. Then you also need to check whether your patient has weakness in the ankle inversion, which is supplied by tibialis posterior, which is innervated by the tibial nerve. Whether your patient has weakness of the knee flexion, which is supplied by the hamstrings, innervated by the sciatic nerve. Okay. So you began with a weakness in the ankle dorsiflexion that was causing the foot drop. But if you have a simultaneous weakness in the ankle eversion, it means the weakness is beyond the deep peroneal nerve. It is involving the peroneus longus. So the lesion is at the level of common peroneal. But if you also have a weakness in the ankle inversion, that means the weakness is even more proximal, involving the tibialis posterior, innervated by the tibial nerve. And if it is also the knee flexors weak, that means the weakness is at the level of the sciatic, because the hamstrings are also getting affected. But does the lesion localization end there? The answer is no. So you also need to check whether you have the weakness of the hip extensors and the hip abduction. Because if these are weak, that means your superior and the inferior gluteal nerves are affected. Lesion is beyond the sciatic nerve. The lesion is at the level of lower lumbar plexus. Okay. Moving forward, you also check for the hip flexion and the hip adduction weakness. Because if this is also affected, the lesion is even more proximal, that is at the level of the pan-lumbar plexopathy. Okay, so remember that whenever you have a patient with foot drop, ankle dorsiflexion will be weak, but you do not stop at that. You need to check for the ankle inversion, eversion, knee flexion, knee extension, hip flexion, hip extension. Each and every movement is important because each movement will add to your localization. Okay. Moving forward, when you have weakness of the ankle dorsiflexion, then once you are done with the motor assessment, you also check for the sensory involvement, right? So if the sensory involvement is absent, your patient does not have a sensory involvement. So the localization can be either at the level of muscle or anterior horn cell. However, if there is a sensory involvement present, the localization will be either at the level of the nerve, the plexus, or the root, right? So that is how you further move forward.